this is the hardest part of doing a deep extubation, and that is getting the patient back breathing. So if you can get the patient back breathing, you're golden, you're good, things are great. But the problem of this comes whenever they're closing skin and you're trying to build your end tidal and you switch them to pressure support and they're still not breathing. Then you have to make a decision. Am I going to continue to try to get them back breathing and do a deep extubation? Or am I just going to wake the patient up? Because 99% of patients are going to breathe when the gas comes off.
Hello, future CRNA. Welcome to CRNA School Prep Academy podcast. I have a very special episode lined up for you today, and it is part of our guest host series where I am bringing current SRNAs on the show for you as a guest host on the CSPA podcast. And my thought process behind doing this is I wanted you to hear from current students, a variety of current students who are at different stages of their CRNA journey, and really allow you to kind of step into their world and hear them talk about what it's like to be a current student dealing with things like difficult preceptors or different anesthesia topics, clinical topics, maybe even things like time management, stress management, things like that. I think these episodes are going to be gold, and I hope you enjoy as much as I always do hearing from current students. I know for a fact that the reason why CRNA School Prep Academy is where it is today, and the reason why I have learned so much is from diving all in, listening to current students along with CRNAs share a wealth of information and really kind of taking all of that information and kind of compiling it into kind of the system that we have created today. And I know that you're doing the same thing by tuning into the show week after week, developing your own method, your own strategy, and your own system for success. So I hope you enjoy these guest episodes. Let's go ahead and get into today's show.
What's up, everyone? I'm David Warren, and welcome back to this episode on the CRNA School Prep Academy podcast. I'll be your guest host today, and today we're talking about a very interesting topic, and that is emergence and extubation, or what we would refer to as waking somebody up from anesthesia. This is a very interesting topic. It's something that we spend a lot of time on learning about all of the intricacies in CRNA school. But today, I don't really want to dive into the textbook. I don't want to give you all of the textbook answers. I really want to go into the OR with you, and I want to tell you and walk you through and show you how we emerge and extubate patients in the OR on a day-to-day basis. So before we dive into that, there are some ground rules that I want to cover with you. Just like there are a million different ways to induce general anesthesia and to put a patient to sleep, most of them are right. There are a million different ways to emerge and extubate a patient from general anesthesia, and most of them are right. There are multiple different ways to go about doing this. However, for the sake of this podcast, I really want to share with you two of probably the most common ways that we see. This is going to be a two-part series, two or three-part series, probably two-part series. This is episode one, or take one, on emergence and extubation. And whenever we think about waking somebody up or emerging and extubating a patient, there are really two big, broad ways to go about doing that. So big, like 30,000 foot view from the airplane, there are two ways to emerge and extubate a patient. The first is to do what we call a deep extubation, and the second is to do what we call an awake extubation. And today I want to cover the basics of doing a deep extubation, and there are multiple different intricacies on each one of those. But again, I want to give you that big, broad overview on how we emerge and extubate a patient in the OR. And we're going to start with doing a deep extubation. And that sounds very much like what you probably think. A deep extubation is when we extubate somebody and they are under general anesthesia. They are deep. They're in a deep plane of anesthesia. And we're going to go into what all that means and what that looks like here in just a few minutes. So before we do that, I'll give you a case scenario just so we're all on the same page. We're going to say this is a 40-year-old female, no past medical history. She's having a laparoscopic cholecystectomy. So we've already induced the patient. She's already intubated. She's on sevoflurane. She's on volatile anesthetic. She is undergoing the operation right now. The surgeon is getting ready to pull the gallbladder out. So the surgery is wrapping up. And that's really the first point I want to make to you about emergence and extubation is you really need to know your procedure. And this is highly important, especially as a nurse anesthesia resident. You need to know your procedure. So know the steps and where you're at in that procedure, because that's really going to dictate when you start trying to emerge and extubate your patient, not necessarily extubate, but when you start trying to emerge your patient, you have to really know the timing of the surgery that you're in. So a good thing to do the night before, look up your cases, find out what kind of the steps in that surgery are. And if you've done the surgery before, then you have a big upper hand because you know exactly where you're at in the procedure. And let me tell you, if you're not in anesthesia and you're looking to go to anesthesia school, you're going to do about 1 million gallbladders. You're going to get very familiar with doing laparoscopic cholecystectomies. You're going to know that like the back of your hand on timing wise. So you know, whenever you see the clips going in and they're cutting the gallbladder and they're about to pull it out, you know things are about to start wrapping up. And so whenever you know your procedure, you can proceed with knowing exactly where you're at and what your timing is going to be. So you don't want to be like 2 hours into your whatever procedure you're doing and you think you're done. And so you start trying to get things in order to emerge your patient and then come to find out you've still got 3 hours left. So you don't want to do that. You also don't want to be on the flip side of that and they're closing skin and your patient is still like not ready to be woken up or not ready to be emerged yet. So you really want to know where you're at in the procedure because that's going to dictate a lot of what you do. And so let's say the gallbladder is coming out. They're getting ready to pull it out of the abdomen. After that, we know the trocars are going to come out. They're going to close up and we're going to be done. So we've got, depending on who's closing, if the surgeon's closing, we've got maybe 15 or 20 minutes left and the stretcher's going to roll in and we're going to be out the door. So we have to plan for that accordingly. So like we said earlier, there are two big broad ways that we are going to emerge a patient. That's deep extubation or an awake extubation. So a deep extubation is what we're going to cover today. And that's where the patient is fully deep. They are under what we call a MAC of gas or a MAC and a half of gas. And so these are, again, I'm not going to dive super deep into all the details of what this means, but I'll give you an overview of kind of what the gases are and kind of where we're at with the MAC value and kind of what all that means. So the MAC value or MAC is the minimum alveolar concentration. And so to provide general anesthesia for surgical stimulation, we usually want the patient between about 0.8 and about 1.2 MAC, somewhere in that range. Will provide general anesthesia as to where they don't have that autonomic stimulation, meaning whenever the surgeon makes incision, they're not going to have significant tachycardia or hypertension, things like that. And so we're going to keep the patient around 0.8 to 1.2 MAC. And again, this is not a pharmacology lecture. I'm not going to go into all the detail about what MAC is and all the gases and all of that. We're just going to say we want the patient around 1.8 to 1.2 MAC for surgical stimulation. And so if we're going to be deep extubating a patient, we want to keep the patient, we're going to actually extubate the patient when they are at 0.8 to about 1.2 MAC. We want them under that deep plane of anesthesia when we pull the ET tube, and then we'll have them slowly breathe off that gas as we're wheeling them to PACU, and they'll just wake up naturally in PACU. So that's the general idea of doing a deep extubation, is we're still under that deep plane of anesthesia. And we'll get into kind of why that's important here in just a few minutes. So we want the patient under the deep plane of anesthesia. So let's say the gallbladder's coming out again and our vital signs are stable. Everything's looking great. We're at 1 MAC. That's perfect. The next thing we would do is we would want to switch the patient to 100% FiO2. So typically in these surgeries, we're running like 1 liter of oxygen and 1 liter of air, which is roughly 55-ish percent FiO2. There's a calculation we can do to figure that out. It's not exactly 50-50. It's more like 54, 55%. So typically we keep patients at about 50-ish, we'll say for round numbers, 50% FiO2. So at this point, we would switch the patient to 100% FiO2. So we'll cut the air, turn on 2 liters of oxygen. And this becomes important because we will look at our monitors to see what our end-tidal oxygen level is. And so just like we look at our end-tidal CO2 level, we also look at our end-tidal oxygen level. And so once that end-tidal oxygen level reaches about 80%, we'll know that the patient can be safely extubated and the patient's adequately pre-oxygenated. And that's super important. And we're kind of going to go down these little rabbit holes as we're talking about these sidetracks. So the reason we want to put the patient on 100% FiO2 is because as you know, most of room air is composed of nitrogen. And so most of our FRC, or our functional residual capacity in our lungs, the air that is residual in our lungs from our breathing, is mostly composed of nitrogen. And so whenever we wash out all of that nitrogen and fill it with 100% oxygen, we buy ourselves a significant amount of time that the patient could be apneic and still remain well oxygenated up to the point of being 100% on their SpO2. And that can last anywhere from about 5 to 9 minutes. You can buy yourself a lot of apneic time with 100% FiO2 and the end tidal O2 of greater than 80%. And so we'll buy ourselves minutes if, for whatever reason, the patient is not stimulated to breathe. We'll buy ourselves minutes while we are trying to rectify that situation. And so that's the reason we want to put the patient on 100% FiO2. So we'll cut the air, turn on 2 liters of oxygen. And then for doing a deep extubation, again, we want to keep that full MAC of gas on board so that when we pull the ET tube, there's not that airway stimulation that we will see if the patient is super light and they're coughing, they're gagging on themselves. That's kind of the advantage of doing a deep extubation, and especially on an abdominal surgery. If you've never seen somebody extubated, chances are if you're listening to this, you probably have seen patients extubated because you're working in the ICU. You know that they cough and they gag, and it's just not a pretty scene. And especially with abdominal surgeries, with hernia repairs, really anything in the abdomen, if they're coughing and gagging, that abdominal wall pressure is super intense, and you don't want to like blow that mesh out that the surgeon just put in there with their hernia. So doing a deep extubation on these patients is quite preferred in the right patient. And so we'll get into that here in just a minute as well. But we want to make sure that the patient is a good candidate for deep extubating in the first place. And so that's really the purpose of the deep extubation, is to prevent airway stimulation, prevent increases in intracranial pressure, prevent increases in intra-abdominal pressure, blowing out everything that the surgeon just fixed in their abdomen. Those would be reasons that we would want to do a deep extubation. And so to do the deep extubation, we would decide this before we went to sleep, or as we're going to sleep, as we're inducing general anesthesia. We would then decide how are we going to wake this patient up? And we're always looking ahead, those 5 or 6 steps ahead. And so to do a successful deep extubation, the patient needs to be an easy mask, meaning that when we are putting the patient to sleep and we're mask ventilating, is it an easy mask? Or are we having to two-handed mask? Are we having to put in an oral airway? Are we having to reposition the head? Are we having trouble masking is really what it comes down to. And so if we are having difficulty mask ventilating the patient's not a candidate for doing a deep extubation. Because if we have problems, let's say we have a full MAC of gas on board, patient's not awake, patient's not responding to our commands, not following commands, not in control of their airway. If the patient stops breathing, we would have to breathe for them. Or if there's an emergency, such as a laryngospasm, we'll get into that here in a little bit, we would need to mask ventilate the patient. So if you can't mask ventilate the patient initially, you need to wake the patient up. You shouldn't be deep extubating those patients. The second thing is the patient a difficult airway? So did I have trouble intubating the patient whenever I DL'd or whenever I used the glide scope, whatever it was the patient a difficult airway? Typically, if the patient is difficult enough that I think I need to get the glide scope, probably not a candidate for a deep extubation. Now, there are exceptions to probably all of the things that I'm telling you, but big broad picture, if I think the patient's difficult enough that I need to go grab the glide scope, probably not a good candidate for doing a deep extubation. However, if it's somebody that is an easy mask, an easy airway, I do a DL, get a grade 1 view, able to put in the tube with no problems, great candidate based on those criteria for doing a deep extubation. The next thing is, how high of a risk of aspiration is this patient? Do they have uncontrolled acid reflux? Do they have uncontrolled diabetes? Do they have autonomic neuropathy? Are they on medicines that would prolong gastric emptying? You really want to think about those aspiration risk as well. And so if this patient has uncontrolled GERD and they wake up in the middle of the night with stuff coming up in their throat, acid coming up in their throat, that's not a candidate for a deep extubation. And so our patient here, will say she was an easy mask, easy tube, no GERD, no medical problems, nothing. Like the ideal person you're probably not going to do surgery on these types of people. Usually it's sicker patients, but just for argument's sake, just for the sake of this scenario, we'll say the patient's healthy, no medical problems, nothing, like the perfect candidate for doing a deep extubation. So after we have confirmed that we can do a deep extubation, we've turned on 100% FiO2. We then want to build our end-tidal CO2. So during the procedure, we typically keep our end-tidal CO2 around 30 to 35, usually on the low end, because as you all know, our drive to breathe in normal physiologic conditions is CO2. It's not oxygen, it is CO2. Those hydrogen ions will directly stimulate the brainstem to cause respiration. That's greatly oversimplified, but that's essentially what happens. And so that building that end-tidal CO2 is what will cause that drive to breathe to kick in. And so it was what we can do is a few different things. We can drop our rate, our respiratory rate, and we can drop our tidal volume. And so we can look at our end-tidal CO2, and we really want to build our end-tidal CO2 anywhere from about mid 40s, 45 to 50 to 55, somewhere in that region. We really want to build that end-tidal CO2, and that will increase that drive to breathe. Now, this is where it kind of gets gray a little bit, because just because you're building the end-tidal CO2 doesn't guarantee that the patient's going to breathe. Okay, there are multiple factors that will play into getting your patient back breathing. And I will tell you from experience, this is the most difficult part of doing a deep extubation, is getting your patient back breathing. And so building that end-tidal CO2 is really the first step in doing that. So we'll drop our tidal volume a little bit, we'll drop our respiratory rate. And then after that, we will reverse our paralytic if we use paralytic. And so typically on a laparoscopic abdomen case, the patient will be relaxed. So we'll reverse that relaxation, and we'll either use sugammadex or neostigmine and glycopyrrolate. And so again, not a pharmacology lecture. We're not going to go into the odds and ends of the pharmacology, but just know that we will reverse our patient at this point. And we want to make sure that we're actually done with the surgery. So make sure that gallbladder's out, trocars are out, they're about to close up, then reverse. You don't want to reverse when trocars are still in the abdomen or gallbladder's still in the abdomen, they're trying to pull everything out. Make sure that we're like actually done, and they don't want to blow back up and put the camera back in and take a last look or anything. We need to make sure that we're actually done. So just and you will get to know the surgeon. Honestly, some surgeons, after the gallbladder's out, they will reinsert the trocars, reinflate the abdomen, and take one last look to make sure there's no bleeders. Most don't do that. And so just make sure that everything's out before you start reversing. After you have reversed, you would want to make sure you're adequately reversed. So you could either check twitches with your trainer 4 monitor. If you have a quantitative or qualitative monitor, and that would be the ideal way to do that. And then you would obviously see a bump in your, once we get to, we'll move on to that in just a second. So make sure we're adequately reversed with a twitch monitor. Then we can see how our end-tidal CO2 is doing, see if we're building our end-tidal CO2. And then we would likely have the patient on SIMV, so synchronized intermittent mandatory ventilation, so the patient can breathe over the vent. And at this point, we'll just look at our monitors, see if the patient is initiating any breaths. And we can lower our trigger down to 1 or leave it at 2, whatever you'd like to do. Typically, if the patient's not breathing, I'll lower the trigger down to 1. And that's the effort that the patient must make to trigger a breath or to trigger that pressure support on top of the SIMV. And so we would see is the patient breathing over the vent. And at this point, we can switch the patient to pressure support just to see what they do. Switch them over to pressure support and see if they're back breathing. And typically, in somebody that's young and healthy, I'll start with a pressure support of about 8, somewhere 8 to 10. If they're breathing over the vent, sometimes I just go to 5. But in older people, you're probably going to need to start like 10 to 12, a trigger of 1, and then just slowly wean them down. On somebody that's young and healthy, you could probably start at a pressure support of like 5 and a trigger of 2 and just see where they are. And this is, again, kind of where some of the art form comes in. You'll look at your monitors, see what their tidal volumes are. What kind of tidal volumes are they pulling with pressure support of 5 or pressure support of 8, whatever you decide to go on. What is their respiratory rate? And more than that, I find that a lot of people really get caught up in their respiratory rate. And there is another number on there that is way more important than the tidal volume or the respiratory rate. and that is their minute ventilation. And what is their minute ventilation? So it's respiratory rate times tidal volume. So if you have low tidal volume, you're going to compensate by having an increased respiratory rate, but your minute ventilation may be normal. And so you really want to look at that number as well. So we're targeting anywhere from like 3 to 5 in that range. Usually over 5, the patient is probably in pain. And there are other reasons that can be, but that's kind of the most common thing after surgery. The patient may be in pain. So this is kind of the time where we're looking and we're assessing what is our tidal volume, what is our respiratory rate, what is the minute ventilation. And so if our minute ventilation is low, we'll be thinking of things like, is the patient too comfortable? How much narcotic have we given? Are we fully reversed? How much reversal did we give? Do we give Sugammadex or do we give Neoglyco? Make sure the patient's fully reversed. If our minute ventilation is like 7, and our tidal volume's like, 600 and they're breathing 15 times a minute, when was the last time you gave narcotic? Or what other adjuncts have we given to control their pain? Have we done blocks? Those are the kind of the things that we're thinking about at this point. But like I said earlier, and I don't want to gloss over this because this is the hardest part of doing a deep extubation, and that is getting the patient back breathing. So if you can get the patient back breathing, you're golden, you're good, things are great. But the problem of this comes whenever they're closing skin and you're trying to build your end tidal and you switch them to pressure support and they're still not breathing. Then you have to make a decision. Am I going to continue to try to get them back breathing and do a deep extubation? Or am I just going to wake the patient up? Because 99% of patients are going to breathe when the gas comes off. And that's one thing that I actually found fascinating in anesthesia school is you can breathe. You can take like adequate tidal volume, adequate respiratory rate under a full MAC of gas. And that was super interesting to me that it doesn't necessarily completely wipe out your respiratory drive. Now, it will decrease it a little bit, but it's not going to completely wipe it out in most patients. There are some patients that it will. But usually it's you can breathe good tidal volumes, good respiratory rate under a full MAC of gas. And so that's something I found super interesting in anesthesia school.
Another daily dose of inspiration along your CRNA journey. It's finally my turn. I heard about CSPA back when it was still called ICU Dreaming About Anesthesia, back in 2019-2020. Life got in the way and I didn't end up applying. Years down the road, I wasn't sure if I was going to apply anymore or if CRNA was still the route I wanted to take. I decided I would apply finally this year just to see what happened and jumped back into CSPA. I got into 2 dream schools here in California. I applied to 3 schools total, 2 acceptances, and will not be taking the 3rd interview. My stats are average, 3.3 GPA, 301 GRE, CCRN, leadership positions at my hospital, local Sigma Theta Tau, retook a class and did a lot of interview prep through CSPA, which is through Nurses Teach Nurses, and with CRNA friends. It is doable. Believe in your dreams, invest in yourself. Thank you, Jenny, Dr. Wilson, and team. I could not have done it without you, and thank you to this community for your supportive nature and advice. I am grateful forever. Thank you so much for sharing the story. Congratulations, you know who you are, and I'm so proud that, again, you took the chance on yourself to just apply and see what happened. And I really think this kind of strikes me as someone who maybe is unsure, right? So maybe the question of CRNA is for them because they feel so unsure about whether they'd be successful or not. And I think this is a very common experience that people don't know if it's for them because they're not certain if maybe they're cut out for it. Maybe they think they're not smart enough or they don't have the best experience or the best leadership or whatever it is. But I can't say this enough that if you don't at least give yourself a chance, you're never going to be able to address potential shortcomings. And it's one of those, and I don't even call them shortcomings, but like, for example, if you never tried to make a basketball team when you were younger, would you have ever made a basketball team? No, you wouldn't. You would never have, because maybe you would try to make the basketball teams and you'd realize, oh, I'm not very good at slam dunking, or I'm not very good at dribbling, or I don't know, whatever. So quote unquote shortcomings or areas for improvement would be, you would never know what it is you need to focus on to make the basketball team. It's similar, you guys. You would never know what it is you need to improve upon to make it into CRNA school if you don't at least start the process of trying. So that's what I hope to leave you with, and I hope you guys enjoyed, and back to the show.
And so going back to what we're talking about in our scenario, getting the patient back breathing is really the hardest part of doing a deep extubation. If you can get the patient back breathing, then you're good. You can cruise. But again, you have that decision to make. Am I going to continue waiting, trying to get the patient back breathing, or am I just going to wake them up? because the thing about the OR is you're constantly under pressure, production pressure, to like turn over, get the patient out, get the patient to pack you, move on to your next case. So that's the production pressure of the OR, and that's something that we have to deal with on a daily basis. So you have to make a decision at this point. Are you going to abort the mission and wake the patient up, or are you going to try to get them back breathing? And again, that's something you have to decide in the moment. But for our scenario, we'll say the patient's breathing. So let's say the patient is on pressure support. Again, she's on 100% FiO2. She's been fully reversed, and she's pulling like 300 tidal volumes with a rate of 10. And her minute ventilation is appropriate. And so at this point, we can put her on spontaneous. And when we say that, that's where we will flip on our anesthesia machine, flip the switch over to manual, which is where we would be bagging the patient. And we would just let the patient breathe on their own, no help from the ventilator. They're just breathing on what we would say breathing on the bag. And so we could look at our anesthesia bag and we could see, if the patient's breathing. And obviously at this point, we'd be looking at our monitor as well. So is the patient taking adequate tidal volumes, and is the patient breathing spontaneously? And what's the respiratory rate? What's the minute ventilation? All of those things that we talked about earlier, we would still be looking at that. How much, mainly I want to see how much did their tidal volume drop when we went from that 5 of pressure support to spontaneous ventilation. And I will tell you this from experience, you will see smaller tidal volumes initially, but with each breath, it will get bigger and bigger and bigger. And so the first few breaths, you're going to see a probably cut in half tidal volume. So if you were taking 300 tidal volumes with a 5 of pressure support, you'll probably see tidal volumes of 100 to 150 initially. And then it'll just slowly start getting bigger and bigger and bigger. And you just let the patient get to that probably 200 to 300 tidal volume range. And then that's where you want to see them when they're breathing spontaneously. So the hard part's over with. We've got the patient back breathing. They're fully reversed from relaxation. She's on 100% FiO2. At this point, I would go up to the patient and I would suction the patient out. So a lot of the time, or I say a lot of the times, all of the time, whenever we put an ET tube in, there's going to be secretions that develop around in the back of the oropharynx around the ET tube. So we'll take our suction canvas or our suction catheter, slide it in, suction out, suction all the goodies out in there. And then we'll put in either an oral airway or a nasal airway. And so this is a little more important on the timing of the oral airway if you're waking somebody up, but we'll get to that in another video. For this, again, we're doing deep extubation. So patients under a full MAC of gas, we can suck everything out back there. If this is a normal anatomy person, not somebody who has a BMI of 50, somebody who's normal size, again, easy mask, easy tube, and a candidate for deep extubation, usually you can get by with putting a nasal pharyngeal airway in, and those are less stimulated than an oral airway. So sometimes I'll just slide in a NPA, nasal trumpet, put that in. Other times you can put in an oral airway if you want. Most of the CRNAs that I've learned from will put in oral airways over a nasal pharyngeal airway. But again, the nasal trumpet's less stimulating and a little, when you're waking up, you don't want gagging and all that. So putting in the nasal trumpet's fine. You can do either. Not a big deal. If you're concerned that the patient may obstruct and there's soft palate, everything's going to fall back, put in the oral airway. You'll fix that problem immediately. So at this point, we've suctioned out, we've put in our nasal trumpet or our oral airway, and we'll take one last look at our monitor. We'll see, again, we're looking at a few things here. What is our end-tidal CO2? What is our SpO2? What kind of tidal volume is the patient taking, and what is their respiratory rate? What is their minute ventilation? And then lastly, we'll look at our gas. So we'll look at our MAC value. What MAC value are we at? Are we at 0.8? Are we at 1.2? Or at 1.6? Are we at 0.7? And we really want to, at this point, assess if the patient is deep enough to extubate. And so when I say deep enough, whenever we put in that suction catheter to suction out the back of their throat, are they stimulated by that? Do they breath hold? And do you see them stop breathing, or do you see them start moving and coughing? Typically, like 90% of, this is a very rough estimate, just in my opinion, but probably 90% of patients are not going to be bucking and moving at a MAC of gas if you're suctioning them. Now, I had a patient last week who was at a MAC of gas and I suctioned his throat, it was just like oropharynx out, and he started coughing and like coming off the table. And I'm like, you're literally under a mac of gas. Like, how are you moving? And what didn't move at all through the procedure. So again, this is why you assess these things. So make sure the patient is deep enough. And let's say if we suctioned out and the patient was coughing, you can see the patient moving a little bit and they're breath holding, you would know now is not the time to pull that tube, because the chances of them being in stage 2 are very high. And so this is kind of where I want to go on this little spiel about the stages of anesthesia. So we have really stage 1, 2, and 3. There's a 4th stage that we don't really deal with. Stage 1 is from induction, from when we push our meds to when the patient goes to sleep. Stage 2 is what we call the period of like hyperactivity. And this is where we see, especially with our volatile anesthetics, we see the patient get tachycardic, they breath hold, they have a dysconjugate gaze, and the muscle spasm a little bit. This is where we see what we call the period of hyperreactivity. And this is very obvious in our pediatric population, especially when we're doing what we call inhalation induction. So on peds, a lot of the times we won't start an IV in pre-op. We will do what's called an inhalation induction. This is all to just kind of tell you guys a point. So when we do an inhalation induction, we'll put the mask over the patient's face. We can do this for adults, but it's not as common, very common in kids. We'll put the mask over the patient's face and we will essentially gas them down. So we'll crank our gas up, turn some nitrous on, and let the patient breathe themselves down with a gas. And as they're going through the stages of anesthesia, it's very obvious when they are going through stage 2, because they get very tachycardic, like tachycardic up to the 180s. And then after they're through that hyperreactive stage, or stage 2, you'll see their heart rate drop back down. And that's when they're getting into that deep plane of anesthesia. And that deep plane of anesthesia is where you're at like a mac of gas. And so going back to our scenario, our patient's in a deep stage of anesthesia because they're under a mac of gas. However, we want to make sure that they are actually as deep as we think they are. So again, suction out the mouth, see their response to that. That gives us a very good idea of exactly how deep the patient is. Another thing you can do is deflate the balloon, the pilot balloon on the ET tube. That's very stimulating because that's literally right up against the tracheal wall. As you deflate that balloon, if they have no response and they continue breathing, you will know based on that they are deep enough, that they're not in stage 2. If they start coughing and bucking, you will know that they are likely in stage 2. And the big reason that we really want to avoid pulling a tube in stage 2 is because we can get what we call a laryngospasm. And so a laryngospasm is where the muscles that control the vocal cords, that open and close the vocal cords, those muscles will spasm and the cords will snap shut. And when the cords snap shut, that becomes a very big problem because we're not moving any air at all. So you'll see the patient tugging here supraclavicularly. You'll see them making like a stridulous noise, some stridor, and then you'll also see a drop in your SpO2 if this happens long enough. And this becomes a very big problem for the patient and for us, because a laryngospasm can lead to negative pressure pulmonary edema. That's kind of the ultimate cause, or the ultimate road that the patient will go down if this is not fixed in a timely manner, is negative pressure pulmonary edema. And that's where the patient is attempting to breathe against a closed glottis. And so once those cords snap shut and the patient tries to breathe, all of that negative pressure that they are creating in their thorax will pull fluid into the alveoli and will cause pulmonary edema. And as you know from probably the patient you've taken care of in the ICU, not what you want. This is a non-cardiogenic pulmonary edema, but it can be lethal in certain patients. And it's something that we greatly want to avoid if possible. And so that's the whole reason we want to make sure the patient's deep enough and not in stage 2, is because we want to prevent a laryngospasm. And again, this is not there's not a topic, not a video about how to treat a laryngospasm or, all the intricacies of that, but that's something that we would want to be aware of. So make sure our patient is deep enough. So just to recap, our patient's vitals are all stable. She's under a mac of gas. She's on 100% FiO2. She's fully reversed. She has 4 twitches back, sustained tetany on the twitch monitor. She's pulling good tidal volumes, normal respiratory rate, normal minute ventilation. We've suctioned her out. We either have an OPA or an NPA in place. She's breathing spontaneously and doing fabulous. Now, we're just essentially waiting for the surgeon to be done with whatever they're doing. So again, this is when they're closing skin, putting last sutures in, putting the dressing on. Next, the stretcher's going to roll in the room, and we need to be ready to move over to the bed and go to PACU. And so that's kind of where we're at right now. At this point, we're also thinking about our adjunct pain medication or our narcotic pain medication. So, and again, we're looking at our minute ventilation and our respiratory rate, our tidal volume, our blood pressure, our heart rate, all those autonomic signs. Since the patient is obviously intubated and under general anesthesia, they can't really tell us when they're hurting. So we look at these other autonomic signs to give us clues about how the patient is doing. And so at this point, we would also work in extra pain medication if we needed to. And we kind of covered that earlier, looking at our tidal volume, minute ventilation, respiratory rate. We would titrate our narcotics or a pain medication or whatever based on that. And I would always say, again, this is not the scenario for this, but I would always say start slow. You can always give more. Give a little bit, see how the patient responds, and you can always give more. And we really just want to titrate it until the patient's at a normal physiologic status. So all of that has been done. Surgeon's putting the dressings on. We're getting ready to move over. At this point, we'll pull our monitors off. We could pull the heart rate monitors off. We can unconnect our blood pressure. And at this point, all we have left to do is pull the tube. And so next, I would make sure I have everything ready. I'll pull the machine closer to me. I will take my mask, my syringe, lay it there, pull the trash can over. We've already suctioned the patient. At this point, we're ready to extubate, and there are a few different ways to do this as well. I will walk you through the easiest way to extubate a patient. Once you determine that they are ready to be extubated and everything is physiologically normal, they're appropriate to be deep extubated. We will look one last time. Our MAC value is appropriate. They're deep enough. At this point, turn up our flows. So turn up our flows to like 15 liters per minute. Cut the gas. So turn our gas all the way off, and then we'll extubate. So we'll deflate our balloon, disconnect the circuit, pull the ET tube, throw the ET tube in the trash, connect the circuit to our mask, and then we will hold the mask on the patient. At this point, I'm doing a two-handed mask and a little bit of a jaw thrust with these fingers here. So holding that two-handed mask, a little bit of a jaw thrust, and then I will look at my monitor to see, is the patient still breathing spontaneously? And so we've already established that they were breathing spontaneously through the ET tube on the bag. And once the tube is pulled, usually you will see bigger tidal volumes because they're not breathing through a tiny ET tube. They're breathing normally through their big trachea, and they can exchange a lot of air. So I will look, make sure the patient's pulling good tidal volumes, still pulling 300-400 tidal volumes, normal respiratory rate. And again, when I pulled out the ET tube, I'm also looking for, did the patient move? Did the patient cough? Did the patient grimace? If that happened, then I will know there's a high chance that this patient may spasm, and I would be very much on the lookout for that in this period of post-extubation minutes after. So as I'm holding that endotracheal, or as I'm holding the mask on the patient, I'm doing a little bit of a jaw thrust. I'm assessing, is the patient ventilating? Are they moving air? Are they exchanging? If they're not, then we kind of have to go down that pathway. Why are they not breathing? Do they just need a minute to start breathing, or should I help them out a little bit, squeeze the bag a couple times? Are they spasming? And those are the kind of the scenarios that we look down. So this post-extubation few minutes are very important. This is when you're truly paying 100% attention to what's going on. Is the patient moving air is really the biggest question. And our patient's doing fine, of course. She's moving air, pulling great tidal volumes, good respiratory rate. At this point, I would move from my two-handed mask with a jaw thrust down to just a chin lift. So I'll use my fingers to lift up her chin, hold the mask on, still see if she's moving air, if she's pulling the same tidal volume, moving air. I will then just hold the mask on her face, no assistance, and see if she's still pulling those same tidal volumes. If she's not, and she's requiring some assistance, a jaw thrust or a chin lift or something like that, then I will know, as I'm going to PACU, I'm going to have to hold a jaw thrust on this patient, or I'm going to have to hold a chin lift on this patient. Because remember, this patient's still under a MAC of gas. She's still under that deep, deep plane of anesthesia. And the advantage of this is we get the ET tube out. So there's not that stimulus in the back of her throat, in her trachea, causing her to cough and everything and wake up terribly. So the advantage of this is she's slowly blowing off the gas over time, and it's just going to make it so much easier for her to wake up. So after that, we'll put a non-rebreather on the patient, move the patient over, disconnect the rest of our monitors. Pulse ox is the last thing that comes off, and then we'll drive on to PACU. And once we get to PACU, we'll give the nurse a report, hook the patient up, get a set of vital signs, make sure that our patient is still moving air. As we're driving to PACU, we're looking at that non-rebreather, making sure that we're still seeing the fogging, making sure that she's still exchanging. And then we're essentially done with our case. That is the rudimentary basics of how you would do a deep extubation. Again, this is going to be a multi-part series. Next, we'll talk about doing an awake extubation. There are some things that are similar, but there are some things that are different that go along with waking a patient all the way up. Thank you so much for watching. If you have questions about this, comment below. I'd love to hear your thoughts and your questions. I will say this, as far as choosing which way you're going to emerge and extubate your patient, either deep or awake, it's largely going to depend on the culture of the place where you work. I've rotated at sites where they're like, nope, we just deep extubate everybody that's appropriate. We'll wake some patients up that need it, but if you're a candidate for deep extubation, you get deep extubated. And then I've rotated through some places who are like, nope, we wake everybody up. Nobody gets deep extubated here. So it's largely going to depend on the culture of where you're at and the group in which you're working. But that's the rudimentary basics of how to do a deep extubation. Thank you so much for watching. I hope you enjoyed this episode, and I'll see you next time.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.